So our next speaker is Mr. Samar Nashev, who is a cardiothoracic surgeon at Papworth Hospital and one of the originators of the Euroscore and one of the originators of the Amaze Trial for concomitant atrial fibrillation.
Amazon.
What did I say?
It's the Amaze.
Amaze.
That's okay. Right. Well, actually, Amazon sounds good. I wish I'd thought of that at the time. I have to say, when Neil Wilson asked me to speak about AF at the SCTS University, I was delighted, and I said, yes, of course. And then when I actually saw what the remit was, which is lessons from the Amaze Trial, who should have concomitant Maze, I very nearly apologized and said, can I talk about something else, please? And the reason for this is that this trial is not really finished. But after a little bit of consideration, I thought, well, we have learned a few lessons, so perhaps I can share some of those with you today. So we all know that when we have patients coming for cardiac surgery, that AF is present in many of the mitral surgery patients, and we also know that it's present to a lesser extent in pretty much every other type of cardiac surgery that we do. And traditionally, for many years, we just ignored it. You know, there was AF, but we were doing a mitral or a coronary or an aortic valve or whatever, and we just ignored the AF. And I still remember to this day the excitement in the late 80s when Raghib Hassan came back to Manchester, where we were both senior registrars. And he came back from the States, having heard James Cox. And he presented to us the fact that there was now a surgical treatment for AF. And he explained macro re-entry circuits and explained the pulmonary veins and explained how the maze would do. And we just sat there completely amazed at this. We just could not believe this was true. And I have also to say that most of us did not understand the word he said. But that was in the late 80s, and things have moved on quite a lot since then. One thing that has not moved on very far is the original and quite ingenious operation devised by Dr. Cox, which was the cut and sew maze. Now, there is no doubt that it's effective in that it has restored sinus rhythm in many, many patients, but the take-up by the surgical community must have been one of the slowest in surgical history. And I think it must be because of the burden of the operation. It's long, it's difficult, it has a lot of incisions and suture lines and loads of potential bleeding sites, so that at the end, I think our experience at Papworth is probably similar to most of yours, in that it was a handful of surgeons in a handful of centers offering it to a handful of patients who had the worst symptomatic AF, and most of the others just avoided it. And then the energy devices came on, and that, of course, changed everything because it made it accessible, so that most surgeons could now do AF surgery, and it became very attractive. And probably one factor that we should not forget is that the cut and sew maze was never really device-driven, because sutures are sutures and they don't make much money. But this was potentially a money earner for many organizations, and there was a little bit of industry drive to push it forward. And as a result, we have seen many devices, which you've heard described, and we've seen many lesion sets, and definitely many surgical approaches, from the full sternotomy down to the minimal access and port operations and so on. So that we have a strange situation now. We have an enormous variability in the approach to atrial fibrillation. And the first variability is whether the patient is going to be offered anything at all. And I think it very much depends on the patient, the center, the surgeon, and which way the wind is blowing as to whether somebody who presents for cardiac surgery in AF will be offered any treatment for AF or even have that treatment discussed with them. There is a huge variability in the lesion set, and we've heard descriptions of those, and in fact, I learned today that the variation in the lesion set is even bigger than I thought it was. There is further variation in the device that is used. And something that hasn't been touched on is how the patient is managed afterwards in terms of trying to restore sinus rhythm or rhythm rate control or medication, pacemakers and everything else. That varies too. Now, we've all seen dozens and dozens of series of just concomitant maze being done mostly in conjunction with mitral surgery, but also in conjunction with other cardiac procedures. And we have seen success rates reported of about 50 to 95%. But in some of those papers, the success rate was essentially one ECG once, sometime after the procedure was done. In fact, some of them, I think, were telephone follow-ups where the patient was asked from 500 miles away whether they were in AF or not. There were very, very few evaluations of survival and quality of life in relation to the procedure, and even fewer evaluations of something we've heard just now, which is the AF burden, which is really how the patient may be in sinus rhythm on that one ECG, but what percentage of the time are they in AF? And you really can't do that without some form of Holter monitoring or a loop device. So the Amaze trial was set up to answer a very, very simple question. Many people are adding an energy source, Maze, to their heart operation when they see patients in AF. So does that make a difference to the patient? In the long term, does this actually have an impact on outcomes that matter to the patient? And the outcomes that matter to the patient is how long they live and how well they feel. So it is mainly survival and quality of life. And if it does make a difference, we wanted to find out whether it is cost effective and that it is worth the investment. Is the difference worthwhile for the investment that we put into it? So this is a really dirty surgical trial. We have not told people how to do the Maze or the ablation. The reason for this is because we wanted to find out whether what is being done now is worthwhile. And we would have shot ourselves in the foot, I think, had we actually instructed people on what we thought was the correct way to do the Maze, for two reasons. The first is that we're not sure we know that we're right. And the second, there is no better way of alienating a surgeon from a trial than to tell him or her how to operate. So we just asked people to recruit their patients into the trial and do what they normally do. But we did ask them to tell us what that was so that we can find out by sub-analysis whether there is some advantage to a lesion set or an energy device over another. So the design was a multi-center restricted to the UK trial, and believe it or not, it is double-blind. That means the patient does not know whether they received a Maze procedure, and the person assessing their quality of life and their ECG also does not know whether they received a Maze procedure. There is no documentation in the notes other than a sealed envelope with warnings saying, open this at risk to your own life. That means you do not open this envelope unless you really, really think that what's in it affects how you're going to manage the patient. Now, this is important because it means that all patients, whether they are trial or control, will receive the same package of post-procedural treatment in both groups. Because what you can't have is the patient who has had the Maze having everything thrown at them, from cardioversion to every drug under the sun, to get them back into sinus rhythm, and those who haven't had the Maze just left to their own devices in their post-operative AF. So the trial will be genuinely fair. And it was funded by the NIHR Health Technology Assessment Section. So we've included all the patients who come to have heart surgery with AF, provided they were over 18 years of age. We've included all cardiac surgery, coronary, valve, combined, and even surgery on the aorta, because they often have AF. But they had to have a documented history of AF that was present for at least 3 months or more. And it didn't really matter whether it was chronic, persistent, or paroxysmal, but they had to have documentation of AF for at least 3 months leading up to their presentation. We decided to exclude redos, and the reason for this is simple. We didn't want to put patients at unnecessary risk, and we don't want people to go around doing dissections in areas where they normally would not do dissections purely to achieve the Maze lesions. We excluded off-pump surgery, again for obvious reasons, because it's difficult to for your average surgeon to achieve the complete lesion sets that they would like to achieve. And we excluded patients who are unlikely to be available for follow-up for more than 2 years, which basically means 90-year-olds or more, unless you really thought they're going to live a long time. Those deemed incompetent to consent. So the primary outcomes, the second outcome was our primary outcome. We wanted the clinical effectiveness measured by survival and quality of life to be the primary outcome. In fact, when we first presented it to the HTA, return to sinus rhythm was a secondary outcome. They didn't like this. They felt that as it's a treatment for AF, return to sinus rhythm should be a primary outcome. So we had to include it as a secondary primary outcome. And the measure of sinus rhythm was going to be by ECG monitors worn continuously for 4 days, and this will be identical to the assessment of their preoperative AF, so that patients who are recruited wear a monitor for 4 days that documents their AF burden, and then after the operation, they wear a monitor for 4 days again. The secondary outcomes are fairly self-evident. We look at 2-year sinus rhythm. We look at overall survival and stroke-free survival. We look at the incidence of anticoagulant-related hemorrhage, because obviously anticoagulation plays a big part in this. There are the usual 3 quality of life endpoints. And then there are the economic endpoints, which looks at resource use from everything to do with the operation, the devices used, the drugs used, and hospital readmissions and cardioversions and everything. So the entire burden to the NHS for treating the trial patients versus the control patients can be compared. Now we're beginning to come into some of the lessons I have learned from doing this trial. We wanted a sample size of 400 patients, which actually is quite respectable. If you look at the 14 or 15 or so randomized controlled trials together as a meta-analysis, all of them come up to about 400 to 500 patients put together. So we have one trial of 400 patients. We thought that will answer the questions. We wanted a minimum of 6 centers, and by surveying the centers, we found out that they conduct between 800 to 1,000 procedures per year, and about 10% of the patients will be in AF, so there should be between 80 to 100 patients eligible for recruitment. We were very modest, and we said we will only recruit half of those. We'll do our best to recruit half of those, and therefore, on that basis, we should have finished recruitment in 18 months. So the first lesson is that it's now 5 years, and we are still recruiting. We will finish very, very soon. Surgeons are really rather bad at overestimating their recruitment prowess, aren't they, Peter? And I have to say this isn't purely a criticism of Peter, because I actually count myself in that. I have not been able to recruit anywhere near the number that I was hoping to recruit, certainly at the beginning. And I can tell you that doing a randomized controlled trial in surgery is very, very difficult. There are many reasons for this, but in the current era, there is so much paperwork to be done, and that involves so many organizations that you can always add a year to your anticipated launch date, and that will be an underestimate. And something else that I have discovered is that as soon as you start a randomized controlled trial, dozens of organizations that you never even heard of come out of the woodwork and expect you to report to them. And I'm not too sure whether these are even legitimate, but there is no choice. And I can tell you for sure that my staff who work on the Amaze trial spend more than half of their time filling in reports and tick boxes for organizations. They spend more time on that than they do on the trial itself. So it is really a huge job. And in comparison to this, Euroscore 2 was a walk in the park. Anyway, there is also the issue of eminence-based medicine, which interferes a lot with the ability to recruit. Because many people seem to know whether a patient will benefit from having Amaze, and will know whether a patient will not benefit from having Amaze, and therefore decide not to recruit on that basis, which kind of restricts your pool of recruits, which is a little bit difficult when you have already said that there is equipoise here and we don't know. There is a bit of a logical conflict in here, which I'm trying to understand, but I probably will never achieve that. So we have recruited 336 patients. The recruitment stops in 2.5 months' time, but I'm pleased to say that even if we recruit not a single patient in the next 2 months, we do have enough to answer the question, because we were very lucky that the dropout to follow-up was actually a lot less than we have expected. So 336 will be enough. If we get to 350, 360, it'll be even better. We will complete the follow-up about a year afterwards, and that is when I'll be able to tell you the results. In the meantime, we can be sure that there are no safety issues because there is no mortality problem or complication problem which is directly related to the Amaze people, the trial arm, which has been shown to be higher than the control arm. So doing the Amaze appears to be safe. So that at least is a reassuring thing. The second thing is that you might also like to know that mortality is pretty high in both groups. And the reason for this is because the patients who are recruited, patients who come to have heart surgery in general with AF, are a really old and sick bunch. And I suspect that previous series were very selective in the patients that they offered the Amaze procedure to. That you offered it generally to the young person in whom you thought you could get away with it with impunity. And there was a certain reluctance to offer it to the average old and sick patient with AF. Now, there are many rules which dictate what you can and cannot say about the data of a trial in progress. And being a stickler for rules, I will have to stick to those rules and not divulge anything. In fact, I can tell you that I wasn't even allowed to look at the data until about 6 months ago when there was a decision that had to be made, and there was no choice but for the chief investigator to look at the data, and I looked at the data for the first time. So for this reason, these are lessons which are not learnt from the Amaze trial, and I will deny that I ever said any of this if you challenge me later. So this has nothing to do with the Amaze trial. But when control patients, that means people who have not had the Amaze, have the same panoply of treatment thrown at them to get them back into sinus rhythm as the ones that have had the Amaze, then the rate of return to sinus rhythm in those patients will really surprise you. And the rate of return to sinus rhythm in the Amaze group will also really surprise you. It is also possible that there is a wide range of success rate in return to sinus rhythm, and that range, the width of that range, is dependent on the operator. And it is also possible that the operator difference may be related to the volume of cases that are done by that individual surgeon, and also related to the completeness of the lesion set. Now, there is a subsidiary question to this, and that is, do we know whether if we get the patient back into sinus rhythm, we have anything better than a pretty-looking ECG? And this is something else that we're looking into because the Amaze trial gives us a fantastic substrate for this. So the HESTER study will look at whether atrial function is restored in these people. And it's a very clever study because one of my colleagues came up with the great idea that you take the patients who have got sinus rhythm through having had Amaze, and then you compare them to patients who have had exactly the same operation, be it mitral, coronary, combined, whatever, same age, same time, same surgeon, same risk profile, but whose sinus rhythm was God-given. And we want to see, is there a difference in atrial function between the two? So the question that we're asking is, how many actually get any sort of atrial function after a concomitant Amaze? And of the ones that, which ones are they who get? Is it the mitral? Is it the aortics? Is it the cabbages? We don't really know. Which are the ones that are more likely to get a functional atrium? And how effective is that function in comparison to somebody whose atrial function is normal? Always has been there, and the only thing they've had is a heart operation. And that study is ongoing, and it's about halfway through, and I think it will be able to answer the question, perhaps, about anticoagulation in the long term. So all I can tell you now is watch this space. Thank you very much.
Thank you very much for that very entertaining and excellent presentation. I'm terribly sorry to have to announce that we seem to have crossed over the 12 noon time when the lunchbox sessions are starting. So unless anybody has any very burning question, I'm afraid we will have to draw the session to a close. Oh, there's one question there.
Hi, I'm one of the doctors from Cardiff. One of the outcomes I was expecting myself from this session is just to find out from across the board, really, how many of we are able to tell a patient that he can come off warfarin, anticoagulation, as a primary treatment after instituting this AF ablation, either surgically or percutaneously. How many of us are confident in telling a patient that he will be off warfarin, not immediately, but after 2 years?
I think the answer to that is universally regarded as none. Mark, would you mind answering that?
I'll just quickly jump up here. I never tell patients before a procedure that one of the motivations for doing the procedure is to get them off their anticoagulant. And I think the decision to stop an anticoagulant is based on their stroke risk score. I don't mean to hark back to it, but this is another area where we don't have a lot of data. We've got registry data. People don't report strokes. You don't follow up every single patient that's had an ablation, so you don't really know what your stroke incidence after an AF ablation is. So I think the safe thing to do is to continue warfarin as you would have used it before the procedure. So anyone with a CHA2DS2-VASc score of 2 or more, continue warfarin. And over a period of time, and I usually have this conversation with patients about a year out, discuss with them where the field is going and what the new data are showing. Patients don't want strokes.
Dr. Cox, would you agree with that?
I think the major determinant of that's going to be what I think the major determinant of that is going to be what cardiologists and surgeons alike decide to do with the left atrial appendage, because I really believe that the atrial appendage is the site of most thromboembolic problems related to atrial fibrillation. So I certainly would not disagree with what Mark said about it from the standpoint of assuming the patient still has an open left atrial appendage. Hopefully that'll change in the future. With surgery, again, a part of the Amaze procedure is to close it or remove it. And so we did follow our patients for 15 years, and we had one thromboembolic stroke in 500 patients or so. So I think that we had good evidence from the surgical side that if you remove and some of those people had recurrences, and probably more had recurrences than we actually thought, because we didn't have long-term monitoring back then. But one thing they didn't have was strokes, and one thing we did do was follow them very carefully. So I've always attributed that not to the fact that they got a Amaze procedure when sinus rhythm. I've always attributed it to the fact they had no left atrial appendage, and I think that's the main determinant about how it'll be handled in the future. In the meantime, I think you have to leave most of them on it, probably.
I hope that gives you an authoritative answer to your question. And with that, I'd like to draw this session to a close. Thank you very much to all the speakers. Thank you.